Hi, my name is Casey and I'm a physical therapy student at Campbell University. Today I will discuss and demonstrate a posterior hip glide with and without physiological motion. But first we need to discuss what normal is. Wise, in his textbook, explained that normal hip range of motion for flexion is 120 to 125 degrees, while internal rotation is about 32 to 47 degrees. The capsular pattern of the hip is a loss of flexion that is greater than the loss of abduction, and the loss of abduction is greater than the loss of internal rotation. Posterior glides of the hip are used to increase the patient's hip flexion and internal rotation. The orthokinematics of hip flexion and internal rotation involve the femoral head moving on the acetabulum. During flexion, the femur rolls anterior and glides inferior and posterior. During internal rotation, the femur rolls medial and glides posterior lateral. One way to provide a posterior glide is to apply a posterior lateral glide through the axis of the femur in supine with hip flexed, adducted, and internally rotated with the knee flexed. In one study completed by Choi and his colleagues, their aim was to find how hip mobilizations affected pain and function in chronic low back pain individuals who had limited hip range of motion. A combination of grade 4 anterior, posterior, inferior, and lateral hip glides were applied to the experimental group, resulting in a significant increase of range of motion within the hip itself. They also found the experimental group experienced a reduction in pain and functional limitations as seen by the changes in their numeric pain rating score and Oswestry Disability Index score. We can apply this study to our patients and know that hip mobilizations might help improve range of motion. Brian Mulligan describes posterior hip mobilizations with and without movement in an article submitted to the Journal of Manual and Manipulative Therapy. In this article, he recounts administering this mobilization on a colleague who had limited internal rotation and pain with movement with success of full hip internal rotation and reduction in pain. Mulligan emphasizes in his article that the patient should not have pain with this mobilization, and if they do, that this mobilization should not be used on them. He also emphasizes that slight directional changes may be needed to the distraction force to enable successful pain-free mobilization. This mobilization is meant to enhance hip internal rotation and flexion. Therefore, when you add movement with the mobilization, Mulligan states, you apply the same distraction and add passive hip flexion to the mobilization. Now I will demonstrate what a posterior glide of the hip looks like with and without physiological movement. In order to do the posterior glide for the hip with and without physiological motion, you want your patient supine on the table, and you want to explain to them that they shouldn't feel any pain with this mobilization technique, and if they do, they should let you know. So what you want to do is strap the mobilization belt around your patient's leg and have the pad in the groin. You can ask the patient to place this for themselves if you would like. So the first thing you want to do is make sure the mobilization belt, as I said, is in the groin and around your hips, and that the release is in a place where you can reach it quickly. You want to flex the hip up. You want to stabilize the pelvis with your hand that's closest to the patient's head. You want to stabilize the pelvis by applying your hand to the ilium and your elbow into your hip. So you're stabilizing here. You want to apply a distraction force with the mobilization belt by pulling laterally, and then apply a posterior force through the femoral shaft down towards the table. And you can do any of the 4 grades of mobilization here. To add physiological motion, you would go through the same steps. You would stabilize the pelvis. You would laterally distract with the mobilization belt, you would apply a posterior mobilization and then flex the patient's hip up at the same time. You can then ask the patient to help you once they get used to the movement. Okay, so what we found in your evaluation is that you lacked a little bit of hip flexion, and what that is when you bring your knee to your chest. So what we hope to do with what we did, the mobilization that we did, is to increase that. And this will help with a lot of your functional activities. Like you said, you were having trouble with squatting, so hopefully this will help with that.